limited. 3. Insufficient awareness, guidelines, and education. Even where support is expressed for incorporating palliative care into humanitarian response, there are a lack of policies, guidelines, and training to support humanitarian actors to do so. And 4, cultural and contextual diversity. Palliative care must consider cultural values and differences. Diversity in values of illness, death, and dying are a challenge for the implementation of palliative care. Existing interventions have been developed within a Western frame and may not transfer easily into humanitarian settings. COVID-19, a catalyst for change? Could COVID-19 be the goad for getting palliative care recognized as critical in existing humanitarian crises? Possibly. But if history is anything to go by, there's a long road ahead to make that happen. In 2017, guidelines for supportive care of people diagnosed with the Ebola virus, a disease with horrific symptoms and an exceptionally high mortality rate, around 50%, and which also brought with it the impossibility of a good death or normal opportunities for families to grieve, did not acknowledge the value of palliative care. A 2018 systematic review describes a paucity of data in reference to palliative care as part of humanitarian healthcare response. Things are shifting slowly, particularly in the development of guidelines and protocols, the area where palliative care experts have been most focused. In 2018, the World Health Organization released a guide on integrating palliative care and symptom relief into the response to humanitarian emergencies and crises. This was a milestone for encouraging the take-up of palliative care in humanitarian settings. That same year, palliative care was included in the Sphere Handbook for Humanitarian Standards for the first time. And yet, there is little evidence of application of these guidelines across humanitarian settings, including in responses to COVID-19. In early April, The Lancet drew attention to the World Health Organization's oversight for failing to include palliative care in the COVID-19 operational guidance for maintaining essential health services during an outbreak. Positively, this has since been updated in the revised guidance. The UN Office for the Coordination of Humanitarian Affairs Global COVID-19 Response Plan still does not include palliative care in its strategic priorities alongside health mitigation and case management measures, nor do any of its country humanitarian response plans. From regional epidemic to global pandemic, we unfortunately haven't come too far. A few weeks ago, I participated in a global webinar on palliative care in humanitarian crises amidst COVID-19. Co-hosted by 4 respected international palliative care networks. I suggested a quick survey of participants on the webinar, asking for a digital show of hands from who in the audience would affiliate themselves primarily with the humanitarian sector or a humanitarian agency. There were no responses. While a rudimentary assessment at best, and taking into account the sudden glut of webinars, meeting clashes, and Zoom fatigue we are all experiencing, the lack of hands was nevertheless disappointing. It was also not surprising. The palliative care sector may be devoted to developing necessary guidelines and proposing essential packages of clinical care for humanitarian settings. But these will be of little use if humanitarian agencies are not actively incorporating palliative care into their practice. For the most dire humanitarian context, the suggestion of essential packages of palliative care, while immensely important, won't be sufficient. The limits of resources remain a significant challenge. Guidelines won't necessarily help to shift a mentality focused on saving lives, and they do not on their own cover all aspects of human suffering in illness and dying which are most individually and culturally conceived. Currently, the vision for palliative care in humanitarian settings is falling short. Expanding our vision, 3 big ideas. As I wrote in a 2019 paper, palliative care and humanitarian action share fundamental goals to relieve suffering and uphold dignity, and both hold an ethical root in the recognition of our common suffering in illness and dying, our compassionate action in response to suffering, and our common humanity. With these shared values in mind, here are 3 ideas the palliative care and humanitarian sectors need to consider together. First, we need an open and honest ethical debate and we need to practice humility. This may be a surprising starting point, but one I think that is perhaps most fundamental for solving some of the biggest challenges. If we're focusing too intently on bridging the best clinical palliative care to every suffering individual, we miss crucial moral dilemmas for supporting whole populations in resource scarcity. How to prioritize limited resources, who to prioritize, and how to support healthcare workers who may be experiencing moral distress in caring for dying patients. These ethical dilemmas are the focus of a new paper in the Journal of Medical Ethics. Even in the COVID-19 response in Spain, a country with a functioning palliative care system, palliative care doctors and nurses have been deployed to deliver emergency care to those amidst severe resource constraints, resulting in the limited provision of palliative care. We need to open this debate in order to overcome such dilemmas. We need to acknowledge that in the most settings where humanitarians are working, healthcare systems are weak and fragile. In the world of COVID-19, many health systems may be about to collapse altogether. We also need greater humility to acknowledge that there will still be suffering in humanitarian contexts we cannot mend, no matter how comprehensive our efforts. Second, we need to come to an acceptance of death and the importance of compassionate care. Humanitarian agencies and actors at all levels, from the strategic and operational down to the intimate level of service delivery, need to remember the fundamental principle of humanity and its aim not to just save lives, but to alleviate suffering. Compassionate comfort and care for the dying is steeped in humanitarian history and ethics, but today, sometimes, humanitarian agencies can bring a certain ego and save the world mentality to emergency response. This can be true for health workers in many parts of the world, where medicine's obsession with curative treatment has relegated historic efforts to relieve all manifestations of suffering in illness and death. In the COVID-19 pandemic, the conversation, even in existing humanitarian crises, continues to focus on how many expensive artificial ventilators a country has, and how many ICU beds can be quickly set up in filled hospitals to treat people with the disease. We often strive to keep people with severe illnesses alive, even when such invasive treatments may be futile for the sickest patients or unwelcome by those who wish to forego medical interventions and to die in comfort, dignity, and peace, or unavailable in contexts where basic pain relief or electricity to run such equipment may be hard to come by. Logical action means accepting that death is not a failure or an enemy to be fought and defeated at all costs. Palliative care, not just survival through aggressive treatment, should be the aim for the sickest and suffering patients whose lives cannot be saved because the treatments don't exist or are not appropriate, or the resources are not available. A humane response to suffering gives rise to compassion. Alongside essential packages of clinical care, we need to tap into the softer approaches of witnessing, sitting, and caring, of taking a moment to feel pain alongside someone or to comfort a colleague. We need to think about these small but potent compassionate acts of palliative care that can be enacted no matter how scarce the resources, and in doing so remind us of the roots of humanitarian action. Third, we need to work in solidarity with communities and volunteers. Lastly, we need to think about who the real humanitarians are and ensure they are central to efforts to integrate palliative care. The world of neighbors, relatives, and strangers who play a central role in responding to any crisis. Most humanitarians are volunteers. Humanitarian and author Hugo Slem has observed in his book on humanitarian ethics, quote, "At any moment, in any day, somewhere in the world, a person is suffering from the violence of armed conflict or the devastation of disaster. As surely as this person is suffering, it is equally certain that someone will be trying to help them," unquote. In COVID-19, many of us have discovered wide-eyed what it means to reach out to our vulnerable neighbors we may have never spoken with before, and to feel connected as a whole community. In richer countries, the Compassionate Community Network recognizes the role of citizens to respond with care when faced with dying and grief, and exist as formalized local networks to support such efforts. Many communities already enduring humanitarian crisis can teach us much about voluntary caring for those who are suffering and dying. We have to harness the power of communities and volunteer networks to provide comfort and presence to those who are suffering, and to provide vital support to families left behind. Local humanitarians may not be familiar with formal palliative care or a strong palliative care culture, but even where there is no existing formal palliative care, we need to look for what is already there organically in the community and build on it. We also have to do away with colonial or paternalistic attitudes to the implementation of what has developed as a Western model of palliative care. We need greater plurality, recognizing that more than one path exists. We need to ensure we are tapping into cultural values and traditions of illness, death, dying, and bereavement. Leadership in COVID-19. For communities all around the world, COVID-19 has urged us to contemplate our mortality and our humanity, a blunt reminder that human lives are precious and that relationships must be treasured. COVID-19 presents an opportunity for humanitarian agencies to more fully comprehend the importance of palliative care in their work, but this won't happen unless we are more open and honest about the discussion we need to be having. Realizing compassionate palliative care in humanitarian crises will take more than the development and implementation of global guidelines. We need a vision for palliative care that is both ambitious, but also humble and honest, and in the first instance meets communities where they are at. This is our duty as a palliative care sector to be promoting. For humanitarian agencies, the occasion that COVID-19 does offer immediately is a time to bear witness, to listen, to capture and document stories of suffering and stories of caring for future efforts. As I wrote in a recent blog, the opportunity has never been clearer, nor more essential to provide leadership in the art of caring in dying and death. When COVID-19 has abated and humanitarian agencies begin to evaluate their efforts, their credibility and relevance can only be boosted through such a service.
Okay, there we go. Thank you, Rachel.
Lines and training to support.
Let me just close that off before it plays itself again. So as I was saying, thank you, Rachel. Very well written document, and I believe the relevance here is quite simply this, that radio operators, regardless of what level you are at, in other words, those that are listening tonight, as radio amateurs on the one hand and non-amateurs on the other hand, South Africa is at the kickstart, the beginning of this outbreak, of this pandemic. And I believe that, and I am of the opinion that each and every single one of us that hears this broadcast, and many of those that we know around us, are going to be subjected to being in contact with either somebody who has tested COVID-19 positive on a mild level, asymptomatic or mild level, all the way through to possibly almost a critical level just prior to them having to go into hospital or intensive care units. We may have to look after our own family members and take care of them, or at least have them take care of us. I don't know. And I feel that we all need to understand that moving forward, as more and more lives are lost and more people are affected and incapacitated in one form or another, that this is going to have a major psychological impact on every single one of us, on each and every one of us. It will have a psychological impact that could be damaging to us as an individual moving forward. Very much the same as many people who are following the, shall we say, a fake news, conspiracy theory type avenues, and they are incapacitated in terms of being able to move forward. This is, again, an opinion of mine, that people are caught in such a fear that they're not going to be able to cope with normal day-to-day living. And then on the other side of the fence, many of us that are subjected to this event may just come out stronger on the other side and find ourselves in a position of being able to be supportive of others, whether they are directly infected or are impacted by means of having to take care of a family member or have been affected due to the loss of a loved one. And my appeal ultimately at the end of the day is to every single person that is listening to actually hear the plea that I make. That if you find yourself in a position that is not your normal self, to rather reach out and to speak to somebody else about it. Seek that assistance. Share your feelings and emotions with others. And then on the other side of the fence, if you find yourself in a position where compassion and humanitarianism is driving you to such a point, reach out and make contact with people, your next door neighbors. I've said this time and time again during the state of disaster. Reach out and ask, are you okay? It is a serious plea. And I felt that what Rachel had written and had put into the podcast is something we all need to hear and understand from another perspective, not a Chad perspective. Chad doesn't like to speak from Chad, because if Chad had to speak from Chad, no. Language itself is another thing altogether. So let's not go down that path. So taking somebody else's perspective, but you know, the issue of the perspective for me was of such major importance, because here we are in South Africa, where we have currently reported, as at last night, having tested 2.1 million people, with 264,184 positive cases identified and 3,971 deaths. Nowhere on social media, nowhere in the news, nowhere have we read or heard of anything that people are experiencing in a personal nature. And I asked myself this question when I listened to Rachel the first time, 10 days ago. Why do such an article when we don't seem to be experiencing the same thing that she is describing? Does that make us South Africans different? And then the penny dropped. And the answer was quite simply this, but we're not even on the scoreboard yet. Until last night. We're now 9th highest worldwide. As we sit at the moment, we are 30,000 behind the United Kingdom. We have surpassed Italy and Spain. And for those of you that have monitored, and I know Zoom will expire in a few minutes, 5 minutes, so I want to close within the next 5. For those of you that have monitored the happenings in Spain and Italy, and the outcry and the suffering and the turmoil and the number of people that have been infected and the emotional impact and the number of lives lost, not only because of COVID-19, but through other means, not always disease or health related. We have gone past them. Italy is only 243,000. We're 30,000 above Italy. 253 for Spain. We're 13,000 above Spain. Those that are ahead of us at the moment is the United Kingdom, Mexico, Chile, Peru, Russia, India, Brazil, and the United States. We are at the beginning of this outbreak. And from this moment onwards, I firmly believe that many people are going to be affected one way or another, whether by means of the disease itself, or this disease in actual fact creating problems with existing comorbidities and all the rest of it, or through the fact that people, family, friends, etc., are going to be lost, and each and every single person, like the rest of the world, will have a story to tell and could be negatively impacted. And my plea is quite simply, people, if you feel or of the opinion that something is not right, that is not normal, please reach out. Reach out to others. Please don't go to the hospitals. ZS6RBJ, ZS6OPS. ZS6VIL, ZS6OPS. Yeah, Baptist, did I just suddenly drop out there from ZS6OPS? All right, well, let me wrap it up then. Okay, so basically where we're sitting at the moment is that the numbers are extremely high and we are only starting. So please, if you are experiencing anything in the negative, rather make contact with somebody else. I've got 3 minutes on Zoom. Make contact with friends and family. Tell them how you're feeling. Don't be shy about it or embarrassed or allow stigma to take hold or otherwise. If you are in a position to help somebody else, please, guys, moving forward, do so. And on that note, I want to say that our worldwide figures are now standing at 12,776,232. And the global deaths is 566,055. At this stage, this thing is not abating. And then there is also now, in this last week, the reports, the results of many data studies that and scientific studies that have been conducted over the last 6 months since the outbreak and identification of COVID-19, that it is also likely now that the coronavirus is not just spread by means of the droplets through coughing and sneezing, but it's also airborne, which is why there is such a high rate of spread throughout the world. And the World Health Organization has now acknowledged that these results are starting to show evidence and proof thereof, and have adjusted their guidelines and protocols to include ensuring that you are now in properly ventilated workspaces, rooms, houses, whatever the case might be. If you are running air conditioners, if your air conditioner actually recirculates the air, rather not use the air conditioner or the heater or the fan that recirculates the air. You need something that will actually expel the air with 1 minute and 45 seconds to go. So I want to close on that and just remind everybody that we'll be back next week, Sunday, 1900 again. For those of you that called up on 2 meters, thank you. Those of you that came up on Zoom, Zoom will die in approximately a minute. So I'll reconnect it if you want to come back and talk to me quickly afterwards. Guys, thank you. Let's just check and see if there's anybody else that would like to add themselves to the bottom of my list. Otherwise, we will close this net. ZS6IP is standing by for any further call signs. Okay, nobody else. Thank you, people. Have a good one. Enjoy yourselves. Next week, same time, same place. During the course of this week, be safe, be prepared, and of course, be happy. ZS6IP is releasing 145.625 for general use. Cheers all.
That, just something, have you seen there was a Gabby that was on the line as well on Zoom?
Yes, no, I've acknowledged her on the list, yeah.
Okay, 100%. Cheers.
Cheers, Pattis. Unai, you want to test your... Oh, Unai disappeared very quickly. All right, cheers, Neil. I'll catch you guys later.
Bye-bye.
Okay, then.